It's my pleasure to introduce Bill Behan, who is the director of the ACCUs, who will be presenting the Janssen Award, followed by Dr. Boris Lorberg, who's the medical director of the ACCUs, who will be introducing today's speaker for the Janssen lecture.
Thank you, Dr. Rothschild, and welcome all to our annual Deb Janssen's Award ceremony and grand rounds. My name is Bill Behan. I'm the executive director of the Adolescent Continuing Care Program here at the med school. We get together every May, Mental Health Awareness Month, and remember and honor and celebrate Deb Janssen's, my predecessor, who formerly led the ACCU and was in constant pursuit of adolescent mental health care of the highest order. Each year we ask our ACCU community to nominate one of our staff for embodying those values. And we recognize them here. So without spending any more time on it, I'd like to announce that our OT extraordinaire, Lexi Sells, is our 2023 Deb Janssen's awardee. And I have just a few words. Lexi started at the ACCU working as a mental health counselor years ago, put herself through school, and then came back a second time as an occupational therapist and has been with us ever since. Lexi stands consistent with the values of Deb Janssen in pursuing excellent, high-level, compassionate care provided to some of the sickest adolescents in the state. Her commitment to our patients is head and shoulders above what anybody could expect. Lexi is known to come in on her day off and cover the rehab department and do whatever it takes. We've been had a vacant rehab director position, so I have had the great opportunity of being Lexi's direct report now for probably 6 months. And I've got to tell you, the can-do attitude, the get it done right, the get to yes effect that Lexi brings to me every day is impactful. Consistently a patient first therapist for our kids. Some of the things from her award nomination that I just thought I would quote: exceptionally going above and beyond to assist youth during dysregulation and unit acuity, willingly coming in to cover the OT department, run groups, taking time to sit with youth in a compassionate, non-judgmental way to provide support and healing while validating their feelings and helping them develop coping skills. I'll share with you a very brief story. We were approaching last Christmas, and the OT department and some of our admins had gone out Christmas shopping for the youth for the holidays. And after we returned from shopping for 30 teenagers, Lexi was astute enough to discover that we had left one kid out somehow. And she came to me, and I want to say it was 8 or 8:30 at night. And we just scrambled and made a quick run to Target and tipped the store over. Came back with, the modest things that this young man had asked for Christmas. And so I thought, okay, that's great. We did that. And I learned a powerful lesson. A couple of days later, this young man was to be transferred to a lower level of care. And so as I was meeting with him, saying goodbyes and stuff, he asked if he could open his gifts. And I said, yes, absolutely. And this young man, after watching him suffer and watching him learn and watching him deal with symptoms and learn behavior and coping strategies, sat there and actually had tears in his eyes and was just so happy to have been included, right? And I won't forget it, because having worked with this kid personally, I've seen him cry many times out of upset, out of rage, out of frustration, out of suffering, and to see us bridge the gap to the other side. Congratulations, Lexi.
I mean, I will keep this very brief, as public speaking is still one of my growing edges, but I just really appreciate the recognition for and receiving the Deb Janssen award. I'm truly humbled to be individually recognized for the work that we all do as a team for our kids and their families. So thank you.
Thank you, Dan. Thank you. Okay, and I'd like to introduce at this time our medical director, also known as the Adolescent Whisperer.
I'll take a picture.
Okay.
But you need to show your plating.
Okay. Yeah. Just don't drop it.
I will let you know.
You'll need some OT then. So thank you for your time. At this point, I want to introduce our medical director, Dr. Boris Lorberg, or as we know him at the ACCU, the Adolescent Whisperer, and he's going to start us off with grand rounds.
Thank you, Bill. Kind words. So it's my great pleasure to introduce Dr. Ryan Madigan. He has an illustrious lineage of training. He completed his clinical psychology doctoral training at Rutgers University, pre-doctoral fellowship at Harvard Medical School, Boston Children's Hospital, and postdoctoral fellowship at Boston University Center for Anxiety and Related Disorders. Dr. Madigan has taught at the undergraduate, graduate, and postdoctoral levels at Harvard Medical School, Boston University, Wellesley College, and Rutgers University. As an attending clinician at McLean Hospital, Dr. Madigan co-founded the DBT Trauma and Exposure Program, otherwise known as the 3E's DBT Continuum of Care. Dr. Madigan specializes in treating youth and young adults with complex presentations that include trauma, co-occurring suicidal behaviors, disordered eating, substance abuse, somatic issues, dissociative disorders, and psychosis. He will tell you in his talk about his research interests. It will be important to know that since 2022, he and his colleagues, such as Dr. Michael Hollander, who gave Deb Janssen's grand rounds here several years ago, have consulted to the ACCU with the goals of expanding the ACCU clinical toolbox and improving our quality of care. Since 2013, Dr. Madigan has founded and led Boston Child Study Center, where he leads multidisciplinary clinical teams treating multi-complex pediatric and adult psychiatric patients with cutting-edge evidence-based treatments. So it's my pleasure to give the floor to Dr. Madigan. Thank you.
Thank you all for having me. Can you guys all hear me okay? Okay. So would like to, I guess, kick us off by raising awareness around a really troubling finding. First, we're not responding here. Hold on. Just a couple of disclosures. And as Dr. Lorberg said, I have been fortunate enough to consult to the ACCU and see just how passionate and dedicated this team has been, and share some of these ideas for how we can better support some of these adolescents who are struggling. so much. So to start us off with a problem, we at this point in our field, we have more evidence-based treatments available and disseminated than ever before. And yet, rates of mental health issues continue to rise. Sort of a unique problem that is, I think, specific just to our field. In medicine, we see treatments getting better and better, life expectancy improving, and the treatment of various medical issues to improve. So why is it that as we have more evidence-based treatments than ever before, mental health issues continue to worsen? So I'm going to introduce this somewhat controversial idea that we are kind of contributing to this problem, right? Would you all feel comfortable asking your patients to diagnose your other patients, right? Probably not. And yet, in a sense, that's what we have going on in our culture. Our culture, our field are coming at these issues from a perspective of basically mental illness. Right, we have such a bias in our culture, in our field, about emotions that I would argue that the very research questions that we ask, the treatment protocols that we develop, are founded on this principle that emotions are symptoms that need to be treated, that need to be controlled, that need to be coped with. Despite the fact that we have a huge body of literature suggesting that emotions are not symptoms, they're signals. They're signals that our brain is using as a tool to tell us about our needs. But when we start off from that starting point, that emotions are symptoms, I would argue that it skews a lot of the interventions that we offer. In addition, that misunderstanding about emotions leads us to a misunderstanding about symptoms, which we'll get to in a bit. And we're still lacking consensus on a common mechanism for trauma and emotion disorders, which I'm going to talk to you all about today. So I think our solutions, and this has been a big part of the work that I've been fortunate to do with the ACCU team, is really at the beginning, we have to change our relationship to emotions. The emotions are signals. These are neurocognitive messages from our mind, giving us critical information about our needs. Further, I'd argue that this concept that I'll explain in a bit, traumatic conditioning, is at the center of trauma and trauma disorder and emotion disorders. And future research is going to look at this treatment dialectical emotion therapy, which is a protocol that we've developed in-house to really try to help some of the most distressed youth with many comorbidities that simply don't respond to the traditional CBT DBT interventions. So just to kind of couch this issue, if you were to get on an airplane and you look in the cockpit and you see all those red blinking alarms going off, and you see the pilots sort of casually covering them up with tape and just sort of dismissing, avoiding them because of the inconvenience, I would hope that you'd get off that airplane. Similarly, if I'm driving one of you somewhere and I draw with a magic marker this arrow to the full line, I would also hope that would draw some concern, right? So if we don't respond to signals like this, right, by avoiding them, by distracting from them, then why is our whole culture responding to emotions in a way that we would label as pretty crazy behavior with other more straightforward signals? So to kick us off, here's a signal that some of you are familiar with and dealing with as we speak. So hunger, for example, is a neurocognitive signal that we are comfortable with in our culture. For some reason, somebody somewhere decided that certain signals are okay and these other emotional signals are not okay and they need to be suppressed. So we're all pretty much in agreement that hunger is your brain indicating. Gotcha. That hunger is your brain indicating a need, right? It's telling you you're low in energy. It's urging you to eat. And depending on how hungry you are, it will depend on how urgent that message is sent. Right, so every emotion is a signal. It's telling us what's happening. It's telling us what to do. And it's telling us how important, right? I don't know how many of you have taken your morning toast out of the toaster and juggled it back and forth as you get it to the plate. The pain signal that you're experiencing is at a moderate level, right? So that's why you can get the toast to the plate. Whereas this pot of boiling water, you simply wouldn't be able to juggle that back and forth because the intensity of that signal would be too much, right? So this is sort of a roundabout way of highlighting that we have these signals that we find acceptable, and then we have all these other signals, these emotional signals that we find are conceptualizing and thinking about as symptoms. And I'm going to argue today that we really need to change the conversation about emotions from the very beginning. So we're going to walk through, it's an interesting study looking at the activation and deactivation in the body when under different emotional states. And I find this really interesting because you can actually see the function of each emotion in these images. So we'll go through one at a time briefly in the spirit of time. So joy, happiness is a signal giving us information that an activity that we are engaged in is good for our well-being or needs, urging us to pursue it. You can see the body's lit up with activation under states of joy. Love, an emotion that is giving us information that some component of a relationship is important to our health and happiness. And again, you can see it here. Pride, sending a signal that there's some trait or ability that I have that I can utilize to get my needs met. And again, signaled here. Anxiety, the fight or flight mechanism, giving us information about a threat, urging us to avoid or try to prevent the threat. And again, captured here. Anger, an emotion telling us that something is blocking our needs and urging us to assert and to protect. You can see that emotion captured here. You see those white hot fists. And now probably the more concerning and stigmatized emotion in our culture, sadness. So sadness is an emotion that's trying to tell you that something's missing. A need is missing or lost, and it's urging you to replace it, which you can see captured here. You see the deactivation in the limbs, urging the body, the person or individual to sort of reflect and acknowledge what's missing. And then there's an activation of sadness, that the discomfort component that's urging a person to do something to replace what's missing. A little bit more controversial, there's plenty of studies by Neese, Andrews, and Thompson that are looking at depression not as an illness, right? Depression is not a disease that we should be treating like a disease. It's another neurological signal that is trying to tell the individual experiencing it something. And it's sort of like your mind is in timeout when you're under a state of depression. So depression is your mind telling you that something is a hopeless way of getting your needs met. We see this in animal models. If you look at the behavior of a grizzly bear in the winter, the grizzly bear hibernates. That hibernation is actually, when you look at biomarkers and behavioral markers, is a state of depression. It's the grizzly bears. The depression is saving the grizzly's life. If the grizzly continued to forage for food, it would starve to death. So it's actually a very adaptive response. And there's solid studies looking at depression as a way of urging an individual to conserve resources. And you can see depression captured here as well. Guilt's telling us basically when we've done something wrong to keep us a part of the tribe. Shame is we'll get into a little bit, is a product of trauma. And jealousy and envy are giving us information about how to protect things that we have and how to pursue things that perhaps we don't have, but we want or feel entitled to. Okay, so So jumping off from this idea of needing to consider emotions as signals and not symptoms, I want to shift to this second concept, traumatic conditioning. So traumatic conditioning, I would argue, is at the center of all emotion disorders. And we can explain how everything from PTSD to social anxiety and depression develop as a result of this process. So this idea came from a first, this concept of a trauma network that was put forth by Martin Bohas, who's the developer of DBT PTSD, evidence-based treatment for complex trauma and co-occurring suicidal and self-harm behaviors. And this is a model for how to understand this experience of flashbacks in the context of trauma. And when we extend this idea a bit further to primary and secondary emotions, which Linehan first talked about in her first text many years ago, we can start to build a case for how to understand emotion disorders and trauma a little bit differently. So as I said before, emotions are signals, right? So first we'll talk about how the emotional process is supposed to go when everything goes well and everything's healthy. So initially, say a need is blocked or invalidated, an individual, their brain fires off sadness, telling us information, something's missing. We then take some action to replace what's missing. That need is restored. And we're brought back to a state of contentment, right? So that emotional signal, that behavior inside our mind is reinforced. And we go on to develop a healthy future. What happens when that does not go well, when a person experiences trauma, traumatic invalidation, breaches in attachment? So again, the need is blocked or missing, person experiences sadness. But what happens if they're in a situation where they are trapped or helpless, the environment does not respond appropriately? It either does not help that individual get that need replaced or makes it worse in the case of abuse and trauma that we're all too familiar with. These two stimuli co-occurring, just like any classical conditioning event, become paired to create a conditioned response. This is what we call trauma. Essentially, trauma is born from this co-occurring experience of having an aversive experience of being helpless, out of control, being paired with another primary experience or neutral, or I would argue healthy neurological symptom or signal, in this case, sadness. So now the person's mind is sort of associating or pairing these two things together. Sadness now is seen as a threat because of the association between the two. From here, we develop, so the individual, any individual experiencing a state of helplessness is gonna develop coping strategies to ensure that this does not occur again. And this adaptation is what we call PTSD. This adaptation causes us to develop secondary emotions. Anxiety, anger, and shame are the two most common. And anxiety is a secondary emotion that helps us or motivates us to try to avoid or prevent any future loss or loss of control. When that emotion fails, we move to anger. Anger urges us to fight against any future loss or loss of control. And if and when that fails, we simply blame ourselves for whatever happened. After all, if everything is my fault, if all the bad things that happened to me yesterday and today are my fault, it's bad for my self-esteem, but it's great for my sense of control. If I can convince myself that I'm to blame, then I'm the one in control over preventing them tomorrow. So these three secondary emotions are at the center of certainly every trauma disorder, and I'd also argue at the center of any emotion disorder that we're familiar with treating. From these secondary emotion responses come secondary behaviors, coping strategies. So a lot of these I'm sure we're all very familiar with. Suicidality, self-harm, dissociation, perfectionism, worry. These are behavioral attempts to accomplish the goal of the secondary emotion, to avoid or prevent a future loss of control. When that fails, we turn to anger or shame. And I would argue you could take any emotion disorder and you could map out the symptoms or behaviors that we're used to treating, and you could understand them through this conceptualization or framework. Does that make sense? So what we call symptoms, I'd argue, are not really symptoms. They're coping strategies, right? So in order to really understand patients who've been through some complex traumatic experiences, we have to understand that we're asking them to put down coping strategies. We're not just treating symptoms. We're asking them to to stop engaging in a coping strategy that they believe they need to survive. I was working with this young man a couple of years ago, and he was bouncing between different programs, one for specialized in suicidality, self-harm, another that specialized in OCD. And he found his way to me for a consultation. I sort of assessed his history and mapped out his symptoms that he was in treatment for on this network, and I oriented him to this. And he took the piece of paper and he turned it vertically. And he said, Ryan, this is it looks like a tree. And I thought to myself, it doesn't really look like a tree to me, but okay, go ahead. And he said, he goes, I just realized why I'm not getting better. Why I've been in treatment for so long. I said, why is that? And he said, well, my therapists are trying to help me kill this tree or weed by clipping the leaves. So I go to this one program to try to treat my self-harm, and my self-harm improves, and then my OCD gets worse. I go to the OCD program and I treat my OCD, and then the self-harm gets worse. He goes, we're never going to kill the tree if we're just clipping the leaves. We have to cut the root. We have to cut the root of this tree to kill the tree. I said, wow, you're absolutely right. And that, boy, does that show me that you understand this model, because that's exactly the point of this treatment, is we have to unpair these primary emotions that you now believe are threats, that you're deploying all these secondary emotions and therefore coping strategies to try to avoid or escape. And if we could unpair that healthy sadness from the association you have to feeling viscerally helpless and out of control, you'd absolutely get better. And that's exactly what we did. I asked him, I said, this is such a great way of, thinking about this. Can I use this? And he, of course, gave me permission to do so. And I've been using it ever since. Remember, we talked about the function of depression, right? So when a person goes through trauma, captured here in this red circle in the center, right? They are forced to survive, right? The way we survive is through these secondary emotions. Anxiety, anger, and shame are the most common. Those emotions and the behaviors that they deploy are what get us through the crisis, right? So picture a soldier in a war zone, right? That hypervigilance, that increased aggression, that's not a symptom in a war zone. That's a survival skill. It only becomes a symptom when we can't turn it off after the crisis is over. Does that make sense? Once a person has survived, has gotten through the trauma, and these coping strategies go from things that got them through the worst experiences or the most helpless situations, and they're let's say that soldier's now at their kid's Little League game, and at the crack of a bat, they're diving for their sidearm because of all that hypervigilance. Now it becomes problematic. And when your mind starts to recognize that problem, effectively, depression is your brain recognizing that while these things saved you, while they got you through the worst of the worst crises, they're now a hopeless way of getting your needs met. You can't get your core needs met through avoiding, fighting, and blaming. And how many of you all can think of patients whose behaviors sort of fit in that function, if you will? Does that make sense? Any questions about this? So I want to, just an old experiment, a study, the still face experiment, that I think really captures this idea of traumatic conditioning. You can see the infant experience what we're talking about. So I'll just share this for a brief moment.
Was she sits down and she's playing with her baby who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this, and then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes.
Any reactions? Everybody familiar with that study? So you can really see this baby is acutely aware of just how helpless it is. The idea that the mother is no longer responding, that the child is essentially on their own, that they don't have that line of communication has been cut. The child instantly starts to experience and become dysregulated. So this child is acutely aware of just how dependent on its mother it is. So if you imagine that happening over and over and over to an individual, that child would eventually start to associate, due to this classical conditioning process, the experience of sadness with helplessness, right? And here we have the development of all these secondary emotions and the behaviors that we were referring to before. Fortunately, this child responded very, very quickly, and it only happened once. But if this was a child's upbringing, right? Think of neglect, or even just think of being invalidated every time you experience a particular emotion. Some part of your need is going to be blocked. And you're going to start to associate said emotion with various levels of helplessness. It could be mild and go on to develop maybe a form of social anxiety, or it could be quite severe and pervasive, and you might go on to develop PTSD or complex trauma. So this is, I think, why it's so important for us to not think of symptoms as symptoms, but to think of them as coping strategies, right? And no body of research, I think, captures this better than the research of Martin Bohas, who developed DBT-PTSD, and Melanie Harned, who developed DBT-PE. These are two treatments for what was previously untreatable. These are individuals who present with both PTSD or CPTSD and co-occurring suicidal and self-harming behaviors. And due to Melanie Harned's courageous work, we not only have an intervention that we can actually use to treat individuals who with PTSD who we were previously too afraid to treat because we were afraid that it would cause them to suicide or self-harm. This intervention not only, when compared to DBT, the gold standard treatment for suicide and self-harm. I mean, think about this for a second. DBT is built to treat suicide and self-harm, and by treating the PTSD that many patients with borderline personality disorder have, we see improvements not only in the symptoms of PTSD, we see improvements in the symptoms of borderline personality disorder. Right? This is a condition that was previously seen as being untreatable. And not only is it treatable, but this research really suggests that borderline personality disorder isn't a standalone disorder. Borderline personality disorder is what you have to do if you're living with untreated PTSD. It's a list of coping strategies. And when you treat that underlying PTSD, you put those coping strategies out of business. And you can do so even more effectively than standard DBT. So I think this really highlights that the need to think of symptoms less as symptoms and more as coping strategies. I think the other thing it highlights is that our definition of trauma, right? So these were only individuals who had BPD and PTSD. But what about the individuals who have BPD without PTSD? Right? I would argue that there's no such thing as an individual with BPD who doesn't have trauma. We just have an ironically invalidating definition of trauma, right? We're invalidating huge groups of people who have trauma by using this rigid criterion A definition. So if we're using the DSM's definition of trauma, this meta-analysis looking at 97 studies of people with BPD, we see that 71% of them experienced a trauma or criterion A event. If we get a little bit more flexible in our thinking and we use the ACEs study, the Adverse Childhood Experiences study, then we will, now we're looking at 95% of people with borderline personality disorder experience childhood trauma. So what about that other 5%, right? I would argue that that's just more an extension of emotional trauma that didn't meet either the DSM or the ACEs criteria. And I think it really highlights that borderline personality disorder is really just severe PTSD that's gone untreated for too long. And when we treat that underlying trauma using either DBT-PE or DBT-PTSD, not only do patients' trauma symptoms get worse, the borderline personality disorder symptoms get worse, and they are 1.5 times less likely to self-harm than people receiving the gold standard treatment for self-harm, DBT. And they're 2.5 times less likely to attempt suicide than people in DBT. I think that's a pretty staggering statistic. And I think this body of research captures just how important it is to see these symptoms that we're here to treat as coping strategies for avoiding some form of helplessness or loss of control. Okay, so DBT-PE and DBT-PTSD are incredibly robust and effective treatments, like I said before, for treating PTSD and co-occurring suicide and self-harm. But what do we do about patients who are not as severe and don't necessarily require a treatment that's that robust? This is where this idea of dialectical emotion therapy came about. This is a treatment that we use all day, every day with some of our adolescents and young adults. And it's really geared towards treating the full array of individuals. It could be folks like us who need to have a little bit of coaching to learn how to see their emotions as signals. Life becomes much simpler when you think of your emotions as signals rather than symptoms that you need to control or contain. So there's it's essentially a 3-module intervention. Each module is meant to sort of address a different level of complexity, right? I would argue that everybody in this room, including myself, could benefit from module 1, where we get sort of reintroduced to our emotions and we kind of begin sort of helping you translate what your emotions are really trying to tell you and think of your emotions as a guide rather than this hindrance that we have to contain. Module 2 would capture just about every emotion disorder in the DSM: social anxiety, OCD, depression, etc. And module 3 would look a lot more like standard DBT-PTSD for those really complex, multi-problem youth and young adults who are just not getting better in any other treatment. Any thoughts or questions before I go on? Okay. So like we did before, the first module is essentially looking at emotions as signals, teaching people how to identify what they're feeling, learn the language of translating what those emotions are telling them, and get into better practice at essentially seeing the emotion as a signal that then we have to go do something about to address the need, just like with hunger. When you're hungry, you eat, and what happens to the signal? It goes away. The second module, which are really meant for youth and young adults who present with, say, multiple anxiety disorders, co-occurring depression. This gets a little bit more into more traditional treatment. We look at an individual's values. We define values a little bit differently than the ACT and DBT worlds. A value in this framework is a principle that governs or guides your life, a principle that you believe is important. It cannot be achieved. And this is a subtle but an important distinction. I've seen values defined in ways like I've seen power and wealth identified as values. I would argue that there are a lot of very miserable, wealthy people, and that we should be careful what we're considering a value. If it's achievable, it's not a value. If it's a process you can engage in, it's a value. Does that make sense? So you can achieve an education, and education is not a value. Learning can be a value, right? You can engage in the process of learning, but the minute it's achievable, it becomes a goal. So this is an important part of really focusing our clients. We want our patients to sort of think of there being really only two main tools. We want them to think of their compass and their map for navigating their life. The compass represents their emotions, and the map represents your values, right? The emotions tell you what you need, your values tell you how to go get it. That make sense? We then do a sort of unorthodox assessment. We look at a person's primary emotional inventory. These are essentially the primary emotions that the person is already comfortable feeling and tolerating, versus secondary emotions that are dominating a person's life. When I shared this information with my wife, she quickly figured out that I have a primary and secondary issue with sadness. When I'm sad, I become kind of an irritable jerk. And she goes, "Oh, is that why every time you're sad, you're irritable and short?" And I said, "Wow, you figured it out." "Yes, and please don't remind me of that next time I'm short," which she does anyway. So we really want to look at an individual less in terms of like what are their behaviors and symptoms, and more what's their relationship to these two categories of emotions, right? So think about your own life. One of the questions we ask: when was the last time you cried? Think about in your life. When was the last time you cried? Right? Probably wasn't as often as is needed. Think about your relationship to anger, right? We have a gender divide in our culture where men are allowed to be angry, but they're not supposed to be sad. Women are allowed to be sad, but they're not supposed to be angry, and both are BS. We're all supposed to be angry when something's blocking our need, and we're all supposed to be sad when something's missing. But we're all sort of part of this societal mental illness where we're trying to navigate our lives without certain emotions, and it just doesn't make any sense. And our clients end up getting labeled as the ones who are mentally ill, when really we, that as a culture, are the ones who are mentally ill. They're just struggling to live in a culture that doesn't make any sense. Then map out the relationship the client has to their primary versus secondary emotions, and get them engaged in what we call values-based exposure. So let's say you're dealing with a client who's got some social anxiety and depression. We'd make a case that the social anxiety that's urging you to be perfect, to not lose control, is actually preventing you from connecting with important parts of your life, important values, building relationships, and that is what's causing your depression. That your depression is actually begging you to detach from this goal of being perfect and having everybody like you. And we're going to now help you engage in what we call values-based exposure. So a values-based exposure is essentially what you think of with traditional ERP, exposure and response prevention, except we're not wasting time on exposures that only teach you it wasn't as bad as I thought, right? How many of you worked with teenagers? Getting a teenager to engage in an exposure that their body is saying, I don't want to do this, that's really hard to do. Getting them to do it on their own, just about impossible. So I think of traditional ERP as being synonymous to going to the gym and just not getting any heavier, right? It's not terrible, but it's not really reinforcing. I think of values-based exposure like going to the gym and walking out looking like Ryan Gosling, right? If that happened after every time I went to the gym, I'd go to the gym all the time. So values-based exposure is an exposure that is connecting you with something that's important to you, right? You're going to leave feeling more connected to a friend or having gotten to know another person, for example. And it's a combination of traditional ERP, behavioral activation, ACT, and DBT. The other thing that's important to know about values-based exposure is we don't have to break the rule, right? Like think of traditional exposure, social anxiety. We're going to go and we're going to deliberately embarrass ourselves to learn it wasn't that bad. With values-based exposure, you don't have to embarrass yourself. You just have to be willing to accept the possibility that you might embarrass yourself while you're connecting with that value. So that this is where it becomes a sort of a hybrid of behavioral activation and exposure therapy. Does that make sense? try one more of these cough drops to get me through this. My allergies have just gotten worse. Okay. So moving on to understanding sort of this third module. The third module is going to look more like traditional DBT PTSD. We're going to orient the patient to their trauma network. Some of you have seen me do this with some of the clients at the ACCU, where we sort of try to take the whole picture and help the client sort of build a narrative to understand how they came to these behaviors, these symptoms that bring them to treatment very honestly and naturally. It's a very compassionate way of understanding behavior that society has labeled in very negative ways. We find that clients instantly take to this idea. They're highly receptive to it. It's a very validating way of conceptualizing their symptoms, and it creates insight. Right? They can connect dots that they have never been able to connect before. Disorders that seemed unrelated, that they were struggling with, all of a sudden seem quite related and linked. And I've never, I have basically stopped using all my DBT motivation tools and MI strategies since this model was developed, because nothing motivates more than insight. When you see a patient connect the dots and understand their symptoms in a way that is truly heartfelt, that in and of itself motivates a client to engage in exposures or make changes in and of itself. We'll then look at the coping behavior inventory, which is essentially looking at all the different behaviors that basically bring them in for treatment that other therapists would label as symptoms. Probably the most important, let me just fast forward here. So one of the key elements of this treatment, beyond what we've talked about to date, is understanding the role that helplessness has played in their life. Martin Bohas describes in his DBT PTSD training that he learned the hard way that these are not symptoms, these are coping strategies. One of his first clients ever that he treated with this protocol, he started with shame exposures. He was this patient was engaging in shame exposures and learned, okay, everything isn't my fault. So it looked like a treatment success. What happened was this client, after finishing that phase of the treatment, made a very serious suicide attempt. And in chaining that out, Dr. Bohas learned that what he had actually done was take away one of her key coping strategies, right? If everything wasn't her fault, then she's back here in a state of helplessness that her mind would rather die than be trapped in basically her childhood trauma forever. So he learned really quickly, this is not a symptom, this is a coping strategy. So what we need to do is we need to treat the helplessness before we can actually treat the secondary emotions. Right? We can't ask a patient to act opposite to these secondary urges if they don't have, if we're just leading them back to a state of helplessness. And what we call them is, or what we call that kind of exposure is essentially an agency activity. It's something that reminds the individual that they are not as helpless as they once were. One example that he uses in this treatment is when the client's engaging in an imaginal exposure to childhood sexual abuse. And this particular client was abused by an uncle who happened to be bald. That's relevant in a second. He has the client standing on a balance board to combat the dissociation. And when she starts to re-experience or feel as though Dr. Bohas is literally like a threat, like the uncle, he would have her literally hang on to his hair and put her hand in his hair and hold on and balance herself on the balance board using his hair, which was an instant reminder that he cannot be the uncle. Sort of an unusual, unorthodox intervention. But you see in this video, the person instantly is sort of back and grounded in the moment and no longer seeing him as a threat. So agency activities are a really important part of the treatment, and they are specifically geared towards grounding a patient in this idea that they are not helpless and therefore can afford to act opposite to the secondary emotion and then listen to the primary emotion. So in essence, what we're trying to do is create new learning through exposures that are going to unpair primary emotions from an association with helplessness so that that primary emotion can go back to informing a patient and their needs, and really introduce them to this idea that there's sort of two types of emotions. There's traumatic sadness and there's healthy sadness. Traumatic sadness is sadness you're stuck in, you're trapped in, whereas healthy sadness is sadness that's trying to tell you about your needs, and sadness you can do something about. So this unpairing of these primary and secondary emotions effectively put all these things, these symptoms that we're working so hard to treat on an individual basis, they put them out of business because they no longer have a function. All right, any thoughts or questions at this point? Okay. So in terms of future directions, this is a protocol that's just been sort of finalized, and we've begun piloting, but it's certainly an area that we want to look at a little bit closer, and not only for individuals with these very complex problems, but for individuals with more traditional Axis 1 pathology as well. All right, any questions? Got about 8 minutes, 7 or 8 minutes left. Questions here?
Hi, this is really wonderful. I look forward to trying to explain that to my patients and butchering it. But I was curious, how would you use this in a patient that has co-occurring substance use? I'd have to imagine if they're actively using substances, you wouldn't be able to use this?
Good question. We borrow the readiness criteria from the DBT PTSD protocol. So if they were actively in withdrawal, or obviously intoxicated during the treatment, that would be a problem. But if they're engaging in substance use in the course of their life, I would absolutely still use this treatment, because that I'd argue that they're not going to be able to stop using because of the function that the use has in helping them avoid feeling helpless and out of control. So for many patients, they don't stop using until you treat whatever the underlying trauma is.
Thank you so much for this talk. I had a question. I may have missed this, but over how many treatment sessions is your protocol?
It would depend on which module. So the first module can be completed in about 4 to 6 sessions. The second module really ranges depending on the client's engagement, but it's roughly 20 to 30 sessions in a short-term course. And then the DBT PTSD model, which is what module 3 is really built on, is delivered in the research studies over about 40 sessions.
I have another question too.
Mm-hmm.
Just a follow up. So are these hour-long sessions, and are they individual versus group or both?
So most of these clients are in a DBT skills training group. And the therapy is really tailored to whatever the need is of the patient. So the more acute, the more therapy. So we have some clients who are once a week for 45 minutes. We have clients who we see for 10, 15, 20 hours a week for treatment in we call it an IIOP. It's individualized intensive outpatient programming. It's not a group-based IOP that you think of, but it's a way of intensifying treatment to really try to keep these kids out of the hospital and in the home where we know change happens.
Thank you.
We have a couple of questions from Zoom land. Any variations with youth with developmental disorders, in particular ADHD or ASD? How might the therapy differ from standard treatment?
Well, it's definitely not a treatment to target ADHD or autism spectrum disorders. But when we're thinking about exposure therapy in general, I don't know that I would be concerned about a person's sort of developmental disability. We know exposure works for everyone and everything. Works on animals, works. I think sometimes there's an assumption that you need a certain level of cognitive buy-in in order to benefit from exposure. But I would argue the exposures would not change much. The way we orient the treatment might, but it's not something we've looked at. Yep.
I'm curious what you think about psychedelics and how they would or would not fit into this approach.
I'm very interested in this new emerging world of psychedelics in so far as it can the way it increases or potentially increases neuroplasticity. I think of these over-controlled clients. This treatment works if we can get the person to experience those primary emotions and process apart the associations with helplessness. Many clients, though, have such a cognitive wall. They're so good at cognitively avoiding that it's hard to get them to actually engage in said primary emotion. And our clinic is looking at ketamine and other psychedelics to really help those folks who are stuck in their trauma treatment and hopefully enhance the neuroplasticity or the willingness to experience that primary emotion a little bit differently. Theoretically, I think it's a really nice fit, but we have yet to test it out.
Another question from Zoom. What are other ideas for interventions to help with helplessness?
The agency activity. Yeah. This is probably my favorite example. So I worked with a young man who had really explosive anger. And he comes into session and he's Ryan, you gotta help me. My girlfriend's going on vacation, and every time she brings it up, I explode at her, and I like just really lash out at her, and then I calm down and I feel like such a jerk. So we mapped it out, and essentially, he was struggling at this point in his life, really just getting back into the workforce, and had very little money of his own, and every time the girlfriend was talking about the vacation, it made him feel sad because he could not go with her, could not afford to go on vacation. That sadness brought him back to his childhood, to his traumatic invalidation as a kid, and reminded him of this helplessness feeling. So without realizing it, this rather neutral topic of a vacation was making this individual basically have an emotional flashback to feeling helpless and trapped as a child. And he was lashing out at his girlfriend just the same way he would lash out as a kid to try to regain that sense of control. So rather than tell him to act opposite to his anger or do some anger management tools, we went after the agency or the helplessness to start. And I said, every time you get really mad about your girlfriend going on vacation, I want you to transfer 25 cents from your checking to your savings. And within a matter of weeks, he had saved $70. So he was having a lot of these urges every time it came up. But what it did was it completely extinguished the anger outburst, because every time he transferred 25 cents, even though the goal wasn't actually to save for a vacation, the goal was to remind him that he has agency today that he didn't have as a kid. As a kid, he would have had to go through a fairly dysfunctional parent to get every need met, much less a vacation. As a young adult, this transfer was a reminder that if he wants to go on vacation, it's within his control now as a young adult. And that simple reminder, as silly as it sounds, completely extinguished this anger outburst that he was having with his girlfriend, and it allowed him to just feel sad that he wasn't able to go. That's another example.
All right. Well, we're out of questions and we're out of time. Thank you so much.